Okay. Okay, so it's 7:31, so we'll get started. So thank you everyone for joining us. This is the World Symposium Highlights webinar. We're thrilled to have you here. Thanks for spending the night with us here for the next hour. So this was, in fact, voted the CFA's favorite webinar in both 2023 and 2024. So we are excited to go through this one with you. Leading us through these important updates is none other than Dawn Laney, a renowned expert in the field, a dedicated genetic counselor, and a passionate educator. And with her deep expertise and engaging approach, Dawn will help us break down the most significant findings from the WORLDSymposium conference, and then what they mean for patients, for families, and the broader Fabry community. So Dawn, thank you for being here. We always love listening to you. For those with any questions, Dawn said you're welcome if you want to just raise your hand throughout, which you'll find in the React. So on the bottom of the screen, there's a little heart and it says React with an arrow. So you can push that. And then you can make certain, thumbs up or questions. Ryan just raised his hand. You'll see that. So you can do that throughout if you have a question. Or there's a chat box as well if you have a question. Or we can, if you want to just hold on to it, we can always do that at the end too. So Dawn, I'll pass it over to you.
Great. Thanks, Julia. Thanks, you guys. I'm always excited to come talk to you. Not only does it help, hopefully, you get some information about the world meeting, but it reminds me what I heard at the meeting because the meeting is pretty intense. This is a great meeting, and there's people from all over the world all thinking about lysosomal storage diseases. And of course, I most care about Fabry disease. So thank you for this opportunity to get my thoughts in order as well as talk to you about it. Um, Here are my disclosures. As you know, I really enjoy working in Fabry disease and want to help anybody else who's working in Fabry disease. So I've got a lot of things going on there. This is just things that I found most interesting. There are so many things that were talked about and so many cool things in Fabry disease to think about, but I tried to keep it to a point where we could actually get it done in 60 minutes, but have room for questions and discussion as we need. This was the most amazing thing that was at World. This is your amazing advocacy team. This is the US and Canadian advocacy organization heads and worker bees, right? So this is National Fabry Disease Foundation, Fabry Support Information Group, and of course, the belle of the ball, your own Julia Alt. Here's my plan. We're going to do a quick run through some terms. I know I do this every time, but the reason I do it is because I think it's really important when we think about all these new changes and things to understand what's changing and why it's important and what's different than usual. This outline is actually wrong. Ignore the outline. We're not going to talk about COVID. I did actually, the rest of it's right. Just the COVID part's wrong. The flashback to 2020 right there and there. Okay. So as we all know, we're made up of cells, and each cell is the basic building block of our body. And there's different types of cells. Endothelial cells line our blood vessels. There's filtering units in our kidneys called podocytes. Fibroblasts are the names for the cells that make up our skin. But almost every cell has a lysosome. And the lysosome is the recycling center of our cell. And that's where we have different enzymes to break up big molecules so we can use them again or get rid of them. And those enzymes in there, their entire job is to make the molecules more useful, to give us the things that we need in our body, and then transform them down the road. In Fabry disease, in the lysosome, people are missing or just a little deficient in alpha-galactosidase A. And without alpha-galactosidase A, this gunk builds up in our cells that are sphingolipids that include multiple things. But the reason you have decreased alpha-galactosidase A is because you have a change in your gene. It means you can't make that enzyme well enough. And if you can't make your enzyme well enough, this is the gunk that builds up. It has a couple different names. Depending on which country you're in, you use more one or the other. But we talk a lot about GB3 and lyso-GB3. So those are two things that can store up in our body. We've found that when we measure things in your blood, lyso-GB3 does a better job of measuring how well you're being treated or what's happening in your body. So we used to only measure GB3, which is something that was useful. It went down when you got treated. but lyso-Gb3 is turning out to be a little bit more useful. The other thing is this lyso-Gb3 and the regular GB3, they also, when they store up in large amounts, send out a distress call for your cells. So it causes inflammation. So it's good to know that not only these markers of how well treatment is going, we know the more of this stuff you have, the more distress calls your cells are sending out. And then the more that you have, of course, it's narrowing your blood vessels. It's not like cholesterol where it lines the walls and makes them thick with cholesterol. This is in the lining of the walls in the lysosomes, and the lysosomes get bigger, and it makes the blood vessels that line the walls of the blood vessels get bigger, and it makes the inside where you put things through narrower. We call the inside part of the blood vessel a lumen. It makes your lumen really small. So just to break all that down in a weird scientific diagram that you don't have to memorize, basically your cells get irritated. They send a distress call. That distress call automates our immune system to do an inflammatory response. And an inflammatory response is basically just what it sounds like. Your cell's like, I am in trouble. Either come kill me or help me. And your immune system's, okay, we're on it. And they go and try to do that. And if a cell is killed, then it becomes scar tissue, or what we call fibrotic, which means basically you're making a big piece of scar tissue of a bunch of cells that have lots of lyso-Gb3 and sent out a distress call, and the immune system went ahead and took care of them and made them into scar tissue. This happens over a long period of time, though. So this is things that you don't necessarily in a newborn, but over time you get more distress calls, more problems, and then you get that scar tissue. And one of the cool things that was at this meeting is that Dr. Berlina, who's in Italy and is doing newborn screening, made us a new diagram. And I love this diagram, so I brought it to you guys. What it's showing is that over time, what we see is storage that increases, inflammation that increases, and then scarring that increases. Because in the past, we just said, okay, it gets worse over time. You know, this is what we're looking at in heart and kidneys. This one actually says, hey, you know, when we do newborns or we check somebody earlier, maybe we can catch people before they start this inflammation or distress calls out to your immune system and before the scarring starts. So that we expect that treatment is going to be more efficient the earlier in the disease process you are. It's not that it's not efficient at all if you're older, it's just it works better the younger you are. And this is nice, a really nice like diagram to me that really showed it a little bit more vividly, the storage of the GL3s and what happens with it. So I was excited to see that. Okay, let's dive on into the new stuff. Any questions about just the general basics before we go into the new stuff? Cool, thanks. Yeah, Gina, what do you have?
Hi, your last diagram there, you were excited because they're leading to believe now more people are agreeing that early or newborn screening is a good thing. Because I'm looking at the diagram and it's saying with the newborn screening, if I'm understanding it, expected ERT efficacy drops off then later in life, right? If they start their treatment earlier in life. So what's the balance?
Oh, okay. So this is a little bit different than the way you're interpreting it.
Okay.
So the enzyme retreatment, how well it's supposed to work when you begin it is better when you're younger and worse.
Okay.
So the drop off is actually if you started enzyme as a new person, not that over time it doesn't work as well.
Yeah.
It's the earlier you started, the better. But
No,
I can
that's what
totally
I'm
see how
getting
you
at.
would think that.
Yeah, no, so I'm getting that. But so with the newborn screening, if they're starting the enzyme at a younger age, toddler, young child,
Mhm.
better in the
Yeah.
long run, which is
Yeah.
what the states have always believed, which is what has been argued here, right?
Yeah, many of the states, not all of them. So
Okay.
every state gets to decide for themselves. And some
Okay.
states are like, yes, let's do it. Other states are like, oh, we can just wait. It's not important to know early. But I think this from Berlina also offers more evidence, as you said, that this is important. We should be thinking about this in newborns.
Okay.
And the other thing I like about this is it shows not just the storage of GL3s, is it also shows us the stuff that happens later. Because before we would give you diagrams that showed like the bigger you are, the more storage you get, and the older you are, the more storage you get. But it never said, oh, then what happens? Oh, more inflammation. Oh, scarring. So I like this because it kind of combines all those things. As you said, that we should do newborn screening because treatment is more effective earlier. And what is happening. It's not just storage, it's other stuff too. And this kind of emphasizes that it's lots of things happening together.
Thank you.
Yeah, sure. Thanks. Good question. Okay. You know, in science, people cure rats and mice a lot of having conditions. So what I call this section is treatments that are currently helping mice with Fabry disease. So these are things that are not yet to clinical trials where we can do them in humans. This is the point where it's like, okay, what are they doing in the mice? And we actually get a whole day of mice studies and studies in cells. And there's some good information there, but on the whole, these are things that are going to take a little while to get to humans. One thing that I thought was really interesting is this molecule that's made by GC Biopharma. And this is a new enzyme replacement therapy. They have modified it so it should last longer in the body, but it's also an injection instead of an infusion. So you would give yourself like you would an insulin shot, except you do an enzyme replacement shot. And they think it's going to last longer. So they're trying it in the mice at the equivalent of once a month. So they took their mice, they'd been giving them enzyme replacement therapy with pegyunidase alpha, which is you may know as Elfabrio. They switched them over to this injections of HMI 15421, and it seemed to really help prevent the progression of kidney, heart, and damage the nerves in your arms and legs or peripheral nerves. So that's kind of cool for a couple different reasons. One is it's nice that it seems to be working in these mice when you get it just once a month. The second thing is if you're getting an injection, you can do it all by yourself, theoretically, once it's determined to be safe and you're not going to have an allergic reaction. And the other is it's always nice to have new enzymes and new therapies to think about. Then we said, okay, what did we learn about symptoms of Fabry disease from different posters and presentations? One thing that is, we're kind of going like, ooh, that's not my favorite thing, to the things that are a little bit more hopeful and positive. One thing that was talking about, and I haven't seen this yet in my practice, is there was a report of several people who had basically a bone infection that causes death at the bone in their hips, which then after you have that, you'd have to have a hip replacement. But more than that, it's really painful. So it's called avascular necrosis, which is just a word that we use when we're talking about the blood vessels dying and they go to a particular part of your bone, and that bone dies and becomes necrotic or dead and infected. And so they were saying they were seeing this a little bit more in patients with Fabry disease. And Rob Hopkin, when I saw a presentation earlier, noted that he sees more severe puffiness or edema in the legs in people who are having hip problems of this kind. Now, I bring this up because in the past we've talked about Fabry's impact on bone, but we haven't really explored it as much as I think it needs to be. And this may be a window into thinking about the impact of Fabry disease on bone in a specific location, the hip, which is somewhere that we've actually gotten really good at fixing hips that have problems. We replace them. But at the same time, if it could be prevented or if this is something that we can watch do better if somebody is treated earlier, I think that's really important to think about. Along with this is there's sort of recommendations floating around that maybe people with Fabry disease should get DEXA scans, which is a bone scan that sees how your bone is doing, looking for osteoporosis or not enough calcium in the bones. And I think that would pick this up as well, because one of the places they look at in a DEXA scan is the hip. So this was just something I thought this is an area we don't spend enough time on, and maybe we need to spend more. So I thought I'd bring this up. Another thing, which was done in mice and patients with Fabry disease, they took cells from the heart and they said, okay, if we look at them really closely and do markers that stain where there's inflammation. Remember, we were talking about inflammation earlier, how when you have too much storage, you get an inflammatory response that's talking to the immune system. They said that they can find large amounts of these inflammatory markers in the heart before you see any damage. So usually what we're looking for in the heart when we do a heart biopsy is we look for storage that forms a cell in the lysosome that's all striped like a zebra. And they're saying that they can see damage and stress from inflammation markers that they would see before they could see zebra bodies. So that's telling us that damage is getting done earlier in the heart than what we've been able to measure in the beginning or before. Earlier therapy, better, I think is what this is telling us. There was also a good poster that was talking about a few cases of lymphedema. So this is again where you like to see this picture where your ankles and legs get really puffy. You can have it other places in your body, but we see it a lot in some people with Fabry disease. And they were saying here they were seeing severely impaired circulation that resulted in some amputations in some individuals with Fabry disease and long-term severe edema. And what it tells us is we need to treat it earlier because it's harder once it's long-term. So there's really great compression stocks now. There's actually ways you can do drainage, whether with a physical therapist or on your own, to get the fluid out of your legs and getting it flowing through the rest of the body. But we need to start earlier rather than later. So not when your ankles are this big, but when your ankles are that big, if that makes sense. And it's something that we've known for a while we need to spend more time on. But I would say that sometimes it's hard to convince people that really they need to take the time to do physical therapy because you have to do it a couple times a week to get the fluid really out and doing well. But it's been done really well, like Rob Hopkins was talking about. We've talked about it a lot. He's really had very good luck with the massage and the lymphatic drainage and the wrapping. Most of my patients at this point are, knock on wood, mostly just in compression socks. That really makes a big difference for them as well. Okay. We learned something cool about pain, which we've been kind of tossing around for a while there. But one of the things they found about pain is we talk about the nerves are impacted by Fabry disease. So the nerves get storage, those same GL3s or GB3s build up in the nerves. And in particular, this study was looking at the dorsal root ganglia, which is just a kind of nerve. And they found that not only does the GL3 store, but then it activates these complement factors. Again, these are things the immune system pays attention to. And when these C3 and C4, complement 3 and complement 4, they've got great names, are activated, then they have more inflammation of a particular protein called TNF alpha. Okay, well, that makes sense. But TNF alpha then makes this other receptor overactive. So think of it like it's like a waterfall. This makes this happen. This makes this happen. And this receptor called TRPV1 becomes really sensitive. And this really sensitive receptor means that you feel more pain and more heat because it's more sensitive than the average person, because of GL3, because the immune system is paying attention. This inflammatory response has made this one receptor in the body even more receptive, even more sensitive. And they said, well, we found this other receptor that does the opposite. It's a cold receptor, if you will. If TRPV1 is a hot receptor, they found the opposite receptor. And they're like, what if we make the cold receptor called TRPM8 work more? Is that going to help decrease what's going on with the activated hot receptor, the TRPV1? So they tried it out. And they don't have good answers yet, but this is something they're really thinking about as a possible target for treatment. And there are medications already out there that their entire job is to make TRPM8 more activated. And that would be an amazing thing. If we could decrease pain and sensitivity to heat by just turning on like taking a different pill and turning it basically like counteracts what's going on, opposites could really help there. So I thought that was pretty cool. Again, this is something that is learned about in Fabry disease, but it's still early stage. They're not doing this in humans or anything at this point. But I thought it was important to say, like, oh, there's more than one reason that people have burning pain in their hands and feet and sensitivity to cold and hot. This kind of goes along with this particular meeting, which seems to be inflammation. And these particular studies were looking at, is it possible that inflammation is causing damage earlier? And we looked at that one poster already that said, yes, it seems to be there earlier. Before you even see storage in the cells that you can see under the microscope, you can see that the inflammatory markers are there. And then it just tried a lot of different markers. So, we always are like, oh, we measure GL3, we look for storage in the cells. We don't think about what other things we can use to measure inflammation. And so what they were doing in this other study is looking at all the different elevated markers of inflammation that you can find in your body. And it was interesting because they found some that were higher in women. They found some that were higher in men. They found some that were higher in people who already had heart disease. And they found some that were, related more to stage of kidney disease. So what we're trying to do is find better ways to measure what's happening in your heart by using these markers. And if they can use those markers, maybe they can avoid some of the bigger repetitive tests that aren't as sensitive. There have been, for a really long time, kidney biopsy readers, they're pathologists, right? And their job is to look at your kidney biopsies and look for storage. Those zebra bodies happen in your kidneys too. But they also look at those filtering units, those deep podocytes that filter things in our body. But it takes a long time. They got under their microscope, they got to count the cells, they got to see how big the zebra bodies are in the cell, and they want to see how much of the cell is taken up with zebra bodies versus not taken up with zebra bodies. They've got to see which cells are all flat and which ones still filter. It all takes a long time. So what they did is they trained a computer, artificial intelligence, to read the biopsies for them. And then they compared what they could read versus what the computer could read. And they found that it's much faster and it does a really good job in trying to measure amounts of GL3 in particular cells. And it's so much quicker. Like something could take 2 days, now takes like an hour. They also were able to look in your urine and find podocytes that used to be in your kidneys, and they can look at storage in those as well. So that would be, if they have a fast way to look at what's coming out of your pee, maybe they won't do as many kidney biopsies. Wouldn't that be nice? Nobody loves kidney biopsies. Important, so important, but wouldn't this be nice? So computers can be helpful. They're not taking us over the world all the time. Speaking of urine, did you know that your urine is even more useful than you thought? So there's been there were several posters this time that showed how out of urine you can get enough cells that you can make little tiny kidney cells in a dish, or what they call organoids. So they're like your organs, only they're tiny and they're in a petri dish. They can do the same thing with heart cells as well. So they can do studies with therapies and with all these little receptors we were talking about, medications, and how we expect things to work. And they can do it all in cells from your urine and putting them in a test tube or a dish, as opposed to taking them out of your body through a biopsy. And one of the cool things was, one of the things we see in Fabry disease is a reduced heart rate, right? We call it bradycardia, just means a slow heartbeat. And the thing that happened first within these little cardio cells, they had a slow heartbeat. And I was like, oh, it's proof of concept, but it's kind of cute to think about, like these cells just having slow heartbeats, just like they would in your body. So interesting, but also very useful for research. I loved this other poster. So this was a poster out of the UK, and they used physical therapists, and they talked to patients with Fabry disease who were a little bit motivated to maybe get a little bit more exercise, right? Because we all know there's limitations to the exercise you can get between fatigue and being tired, between having pain and burning. But they basically got together with a physical therapist. They talked about what their limitations were, what they could do or couldn't do, the time they could do it, the time they couldn't do it. They got them a friend, they got them a device, and they got them education online. And they were really able to develop like escalating exercise plans. So plans that got a little bit more, a little bit more, that help people with Fabry disease be able to be more active in a way that wasn't causing them major pain or having them drop out. They were able to sustain that pain. Stay that exercise. Yes, Ryan.
Hi. Do you happen to know if they found that it was more strength training or cardio that kind of helped that?
They were doing mostly cardio. They were kind of focusing on how do you gain it so you can get more active with movement. And they tailored what type of thing. So they did have some people who did dance. They had some people who walked. They had some people who swam. They had some people on a recumbent bike. But they really tailored to what they wanted. So I'm sure that if somebody was like, I want to do more strength, they could figure out a way to do that. Because physical therapists really are the experts in how we move our body and how to plan to move our body better. For everybody, right? We're all couch potatoes. But with Fabry disease, you've got more things to think about. But they're the perfect people to do it.
Thank you.
Yep, thanks. So I just like this poster overall. And the woman presenting it was the primary author. She's like, they never think about us in genetics. They never think about us. And I was like, well, now they're thinking about you. You did good. Okay, so what did experts learn from talking to you guys? There's 2 great studies I want to talk about, both by your amazing fearless leader of CFA, which is Julia Alton, And she had one poster that was like, okay, let's learn about who has Fabry disease in Canada. Let's understand it, because only by understanding who has Fabry disease and the impact on their lives, we can't, help fix what's going wrong. So this was interesting. There's 42 people who answered the survey. As always, women took the lead, and there was more women in this study, but still a good representation for men, 31%. 86% speaking English as their primary language, 14% who spoke French. Makes sense, right? When we think about the breakdown, it was predominantly people who were white, but also had some First Nation and Middle Eastern representation. When we think about the concerns that were really uncovered here, one of the things was really something that we know, but it's important to underline, that it takes a long time for people to get diagnosed in Canada with Fabry disease. So, 36% of patients only got diagnosed after 9 years of trying to find answers. And 26% of people went to 5+ doctors. The other thing is there was one person who saw 50 to 60 doctors for being diagnosed with Fabry disease. And I was like, that's a lot of doctors. That person went from person to person to person over how many years? Another thing that was really underlined is many people have to travel a long distance to get to their medical appointments. And this costs money, and this is not money that insurance reimbursed. Also, looking at the number of days people have to take off work because they're dealing with Fabry disease, whether it's a symptom or actually going to appointments. 43% of people who responded said they take greater than 10 days off work because of Fabry disease. That's a big impact on your earning ability, big impact on getting your job done and the stress about that. So I thought this was really important to underline as well. And also there was the times per year that people feel they're seeking medical attention for medical issues. And 33% greater than 10 times. That's a lot. That means that things are still happening with your health that you need more input on, and things are not necessarily getting sorted out right away. And because, it's a great poster, there's some proposed solutions, which is financial support to help people who are traveling from far and having lots of appointments, and also more provider education to try to get people diagnosed earlier. So this was a really just aesthetically pleasing poster. Like the graphs were very big and they were great to read. And also it had good information on it. So kudos to Julia for putting this cool thing together. Also an important poster from Julia and her co-authors. This is lived experiences living with Fabry disease and with US, Canada, and Japan. So you remember in the past, we did talk about a similar study that was in the US and Canada, but this one expanded it out, asked some different questions, and included our Japanese friends as well. I think some of the coolest things we learned was that a lot of people, women with Fabry disease, feel a stigma with having Fabry disease. And this was directly associated with disease inheritance and the guilt around that, as well as societal pressure and prejudice against having a genetic disease like Fabry disease. And you can see that in Canada, 64% of people were really concerned about the stigma and the inheritance of Fabry disease. Japan was even more at 89%, and the US was 40%. That's a lot of people who are still feeling a lot of pressure and stigma, both internal and external, from having a Fabry disease in a way that you can't control. Like you can't control what you pass on, you can't control what you have. But I think it's important to underline it, right? To say people are still feeling this way. How can we help them? How can we change society? That's hard, but we can do it. How do we change how people feel about themselves? We can change that too. So things to think about. Speaking of things to think about, mental health was also really important. The impact of Fabry disease on women's health, mental health. And you can see that really everybody saw this as an issue. 77% Japan, 80% US and Canada. This is definitely something we need to talk about and think about. When we look at how women felt they were treated by their physicians compared to their male companions or cohorts, you can see that they felt in the US and Canada, still maybe men are getting more attention, more care. In Japan, and the US also felt particularly strong about this with 80%. And then feeling that your primary care doesn't understand Fabry disease and its impact on you as a woman, you can see that was also a really high number. 77% in Canada, 70% of US respondents, and 41% in Japan. I think the summary for this whole slide is we have more work to do with healthcare providers in understanding Fabry disease and its impact on women. And we need to help society as a whole understand that being an individual with Fabry disease shouldn't have the stigma or any prejudice against that. And then helping individuals with Fabry disease understand or feel better about the fact that it's a genetic disease and they could have passed it on or could pass it on. Okay. Julie, anything you'd add for those two posters since we have you as the author right here?
Yeah, thanks, Dawn. No, I could listen to you explain things all day. You did a great job.
Yeah, I think one of the interesting things is when you do a poster, you stand by it and you kind of have to give a summary of what's on your poster to people who are asking all sorts of questions. Like you'll have pharmaceutical representatives come and talk to you about it. You'll have other patients come and talk to you. Then you have healthcare providers come and talk to you and the basic scientists. And everybody has different thoughts and different questions about it. So it's kind of cool. You feel like you really get people understanding or trying to be interested in what you're working on. So, what have we learned about the treatment that you're using when you have Fabry disease? This is kind of good stuff too, right? One of my favorite studies was that they found that treatment with ERT or migalastat, so that's our chaperone therapy amicus, improved stability and sometimes even allowed improvements of heart disease. Early treatment worked better, but later treatment still worked. So I thought this was really nice because it was a study focusing on women and the impact on their heart, and basically learning that the treatments that we're doing do make a difference. And I think we need to underline that sometimes. This was really useful for me. I don't know if it's going to be as useful for you guys, but one of the things that's a problem when people are taking migalastat, or as people call it, Galafold, is that you want to see if that Galafold, if we take a sample of blood, is it increasing the amount of enzyme that somebody has, the alpha-galactosidase A enzyme? And we weren't really seeing a measurable good amount of enzyme increase from the lab tests we were doing. And so we stopped doing it because we're like, this isn't working. It's not showing us what we need to show. And this Lenders and everybody, Lenders is a great doctor, healthcare provider who is in Europe, and they always have the coolest studies. So in this particular study, he got together and they found that if you take blood at least 24 hours after somebody took a dose of their chaperone therapy, of their migalastat, that's when you get the true measurement of what's going on. And the reason for that is that the chaperone is still bound to the enzyme if you do it the same day you took the pill. And so in the test tube, it's doing its job of being bound to the enzyme, but it means you can't measure it. So basically, because of the medication that's in your bloodstream, we couldn't get an accurate test if you took it 24 hours after you did it. So it tells us that what we need to do is we need to take blood to measure enzyme at least 24 hours after our patients took the medication. And I actually put this into practice. Someone who had really been curious about their enzyme levels and Galafold. And I did. I took a sample and I didn't do a dry blood spot. I sent the tube to Mayo and I ordered leukocyte and plasma testing, and I got a great result. So this is really just one of those things that reminds us that we think that when we take blood, we can measure what's going on in the body, but sometimes there's other things that are factors that are impacting what this result is going to tell us. In this case, the time you take the pill for Galafold or migalastat really impacts what's going to happen in that test tube that we can measure. Interesting, right? Already in practice. All right, so how about egalsidase beta, that's Fabrazyme, in kidney disease? Well, they had a really nice study that was showing that, I think this was a registry study. This showed that when you have chronic kidney disease and you take like egalsidase beta as enzyme replacement therapy, the earlier you take it, the better the impact is on your kidneys. And it can stabilize your kidney function so it doesn't progress as rapidly, following the path that we'd expect if somebody who was not treated and had Fabry disease. They cared most about, did it show also that it costs less money if you keep your kidneys stable versus going into kidney failure and dialysis? And the answer there was yes. It was yes, for sure. That helps a lot. So this was just a nice reminder that doing enzyme replacement therapy, in this case with egalsidase beta, is really helping our kidneys. Of course, the earlier we start it, so if you're already in kidney failure or chronic kidney stage 4, it may not help as much. But in each case, it's still stabilizing the kidney function and saving money for you and for the health system. That's important sometimes when people are trying to determine the efficacy of a treatment and they're like, oh, it's not saving us any money. We're not going to keep paying for it. In this case, it's just showing that, oh, it is worth their money. So, yeah. This one is one that I've been waiting for forever. And I'm sorry, this is an ugly slide, but Berlina, our same friend who published on newborn screening, gave this great talk, which was looking at the registry. And one of our biggest questions is, we know that enzyme replacement therapy doesn't make it through the blood-brain barrier. It's a big molecule, it can't get through. So does it help with decrease the risk for stroke in people who are on enzyme replacement therapy? This one is looking at agalsidase beta, which is Fabrazyme, and it found when it compared people who were on treatment with agalsidase beta and those who were not on treatment and had Fabry disease, and they tried to match like classic to classic, later onset to later onset, and they looked for at least 5 years on therapy, they found a decreased risk for stroke in patients on therapy. And when they started like, okay, does it change if they're on therapy and on anticoagulation therapy? They didn't really get a good answer there. But when they looked at arrhythmia and kidney disease and risk for stroke, it didn't change it either. So there seems to be an improvement of risk to have a stroke when you're on therapy. Of course, they focused only on people who were on this particular enzyme replacement therapy, agalsidase beta. They focused on a dose of 1 milligram per kilogram. But on the whole, this was great news because we do want to hear whether enzyme replacement therapy helps decrease the stroke risk. And it did. It's not saying nobody gets strokes, but they were looking at first stroke, which I think is really interesting. So it's not just if you've had a stroke, are you less likely to have a stroke again, which they did show in a different paper like last year. But this year they said there's less likely that you're going to actually have that first stroke. Does that make sense? And the way they counted is like number of strokes per patient years, which sounds really weird, but just recognize that they were just taking a whole bunch of data and comparing one person to another person. And the way they ended up doing the measurement is patient years. This was actually a poster that I got to present and I was really excited about because this is something I've cared about for a long time. I used to have young men who would come to me and they were like 12, 13, 14. They're like, Dawn, I'm so short. When am I going to grow? And I'm like, I don't know. But I could look at their parents and be like, well, it looks like you're supposed to be a little bit taller, right? One of the little guys was talking to me, was 5'2". His parents were like 6'1" and 6'3". You know, he wants to know when he's going to be tall, like his big sister, his big brother, and his mom and dad. And I said, I don't know. But I noticed that by the time he hit 20, he was 6'2". And he'd been on therapy since he was 14. And I was like, okay, there may be something here. Maybe people are able to grow better when they're on therapy. Because theoretically, you know, people have growth spurts, right? There are people in this world who are men and women who start out real short and then they get a big growth spurt and they're tall. But you don't usually jump percentiles that much. And by percentiles, I mean like, so you're real short, that would make you like under 50th percentile. 50th percentile is like what the average person would be. So if you're under 50th percentile, you'd be shorter. If you're taller than 50 percentile, you'd be taller. But what we were seeing is that men with kids with Fabry disease tended to be shorter than average. So they were under 50th percent. And then they didn't do a big jump like when they were not on therapy. So what they did is they compared those not on therapy to those who were on therapy. And then they saw what happened when you started therapy. And what they found is that boys had noticeable improvements after being on enzyme replacement therapy compared to those same ages when they did. In fact, there was a 6.7% increase in height and 5.5 in weight. And when you go to a Fabry meeting now, you will see that people are of a stronger weight than maybe they had been in the past, right? Sometimes if you look at grandpas, you look at uncles, you saw they were really like small men, right? They were shorter than the rest of their family and they were slighter, they were skinnier than average. And part of that is because their body was just working so hard to fight Fabry disease, plus the problems with keeping food in your body when you've got gastrointestinal issues. And what they're showing here is that it looks like what's happening is they can swing from fighting Fabry disease to growing and getting bigger, which I think is like life-changing, right? So the biggest time they grew when they were on enzyme replacement therapy was between age 14 and 20 years of age, which is when your average guy is going to do their growth spurt. So they were doing a growth spurt just like the other guys. And I love that. Their biggest weight growth was before that, though, when they were 3 years old to 11 years of age. So they were able to gain the weight and then gain the height kind of in succession, like we'd see with your average kid. Women, they didn't see as big of a difference. However, between the ages of 3 and 11 years of age, and women tend to have growth spurts a little bit earlier, like right before their first period is their biggest growth spurt. They saw big changes there, but they weren't clinically significant. So we do know that when we look at some of those other studies earlier, women who are girls who were not on therapy didn't have much of problems as compared to the men with growth and height. So that's not too surprising. Sorry, we're still talking about egalsidase beta, but they had some good stuff. So egalsidase beta, they tried to speed up infusions. They were like, okay, are you stable? Are you new to therapy? Let's see what we can do with some pre-meds and really pushing that drug in fast. They found that they could get into 20-minute infusions of 1 milligram per kilogram of egalsidase beta with pre-meds of Tylenol and Benadryl. That's pretty crazy. 20 minutes is awful fast. But it worked. And we actually had a patient who did this study and it worked for him too. So I thought that was, you should have seen me though. I'm like staring at him during his whole infusion. I'm like, how you feeling? How you feeling now? But we did great. There were 2 men in this study of classic Fabry disease and they got down to 40 minutes, which is not 20. But what happens, they went to 20, they had a reaction, they went back up to 40 minutes. And more importantly, their lyso-Gl3 was low and stable. So the faster infusion didn't make the Fabrazyme or the egalsidase beta work, not as well. It seems to be just as stable. So that was kind of cool. Kind of excited about the idea of, as people are moving along, seeing if we can get them to faster infusions, less life impacting. Moving to a different enzyme replacement therapy, pegunigas alpha, or Elfabrio as we know it now. They did some cool studies that were looking at different ways that you could figure out why pegunigas alpha gets into the cells. And this big old diagram is just to show you that what happens usually with enzyme replacement therapies is they go up through your bloodstream and they go to a cell and they look at these, see these little blue Ys? Those are the things that help the enzyme get into the cell, whether it's the stuff you make or the stuff that comes out of your bag in the IV. Most of the way they get in is called these mannose-6-phosphate receptors, which are just these receptors that sit on the cell and help things get in. Turns out that when they looked at pegunidas alpha, it doesn't go through that same way. It gets into the cell, it's doing a good job, and they can see it's going in the cell, the way that you would through a mannose-6-phosphate receptor, but it's coming in a different way. How? They're not quite sure yet. But there's something different about how it enters the cells because it's in the body longer. We'll have to see why that is. But I thought this was a good teaser to say, hey, this is not only a new enzyme, but it works in a slightly different way than what we saw happening with egalsidase beta and egalsidase alpha. This is another dosing change that they were looking at. This is pegunidas alpha again, or Elfabrio. And they did a long, long study that says, can you give a higher dose, so 2 milligrams per kilogram, every 4 weeks instead of every 2 weeks? So this is once a month infusions. And it took people who were stable on 1 milligram per kilogram every 2 weeks, so like your standard dosing, and that was egalsidase beta, and they switched them to 2 milligrams every 4 weeks. The original study was 1 year. That's long, long ago. And then this is 3+ years on therapy for everybody who's in this study. So at least 4 to 5 years of on this medication every 4 weeks. There were 3 patients who had to go back to every 2-week dosing because their kidney function was getting a little bit worse for one, and then for the other 2 because they were having some pain crises. So they felt that maybe every 4 weeks wasn't good enough for them. But everybody else was able to stay on every 4-week dosing. The plasma GL3, lyso-GL3 was stable for women, and there were some increases in the men. They consider them not significantly increased, but you'll just have to keep watching them, right? Because you don't want the lyso to be traveling upward. You want it to stay downward or stable. But they did say stability in pain and quality of life. But they said we definitely need to pay more attention to what happens with the kidneys. So every 4 weeks may work for some people, may not work for everybody. but the data show that it looked pretty good on average. Again, just trying to make treatment less impactful in your daily life. Any questions about those? I just went through a lot of little studies that each give us one little nugget of information. But the next thing I'm going to do is talk about new treatments and clinical trials. How are we doing on time, Julia? I can't see my clock. Oh, I got it. Okay.
Hey, yes,
We're
we're
doing
at
great.
we're at 8:17. Gina has a quick question, it looks like.
Yep, Gina, what you got?
Sorry, quick question. Way back on the slide, and you don't have to go to it. Regarding megalostat,
Yeah.
fold, whatever way you want to. So when was the information published? Because I hadn't heard. I'm out of the loop, obviously. The information that says that it has shown efficacy for cardiac issues, because up until, let's say, the last couple of years, they hadn't really shown any information regarding the heart, but they had information regarding kidney. So that's exciting to me that they have shown that it's been good treatment for the heart so far too, then, especially for women. Yes?
Yeah.
Did I get that right?
Yep. Yeah,
Okay.
absolutely. And I agree, it's very exciting. They did have some data that they really like to show that was in the study they used for approval, but that's mostly in men. This
Okay.
one here just came out from Linders like just now.
Okay,
So
so
it's
it's
new.
newly published.
Yeah.
Okay, perfect.
Yeah, and I didn't look to see if it's something that you can look up at PubMed right now, but
Okay.
Linders is the name of the doctor. So
Okay.
you can look Linders women treatment, and I bet you can find it.
Perfect. Thank you.
If nothing else, the abstract will be published soon too. So that will
Okay.
be available.
Wonderful. Thank
Yeah.
you.
You're welcome. It's good stuff. I like the good news stuff too. All right, so let's talk about what's out there. As you remember, when we look at how we treat Fabry disease, we can replace the enzyme. So you don't even try to use what's there. You just give it back through an IV in the arm. You can try to, if you've got enough enzyme, you can use like a chaperone therapy like Galafold to see if that'll work well enough for you to make enough enzyme stability and not get your enzyme thrown out with the trash because it's a little malformed. And those are kind of the big things that we're going to talk about today. There are other mechanisms. Gene therapy is basically just replacing the enzyme level to make it work better in your body as well. It's just kind of a more long-term fix than an infusion every week or every other week or every 4 weeks. And then there's substrate reduction therapies, which really weren't talked about at this meeting much at all, but are in clinical trials. So substrate reduction therapy is a way that tries to get around the roadblock of your enzyme. So I like to think of it like if you're on a highway and you're moving along and there's going to be a traffic jam that stops all traffic, like 3 exits down, you often will exit early. And that's kind of what we're doing with substrate reduction therapy. We're trying to exit with our molecules before they hit the roadblock. Substrate reduction therapy. But we're not going to talk about that much today because there wasn't any new information. But just know that there are clinical trials open for that, right? Well, they're not open. They're chugging along. They already have everybody in it they want. And there's this is out of Sanofi, and we'll see how it works. They'll probably give us all sorts of good information next year. But they just got everybody in their studies, like in November and December. So that's why they're not giving information out yet. The previous studies they did was how safe was it, and it was found to be pretty safe. And they looked at how effective it was, and it seemed to clear out the cells of the skin and the kidney and the heart. It just took longer. So with enzyme replacement therapy, we see changes much earlier. With substrate reduction therapy, it seemed to take a year. And these are in men with classic Fabry disease who'd never been on therapy. So we'll see. But it was kind of exciting because substrate reduction therapy is a pill, and it would work theoretically for anybody with any mutation in their gene. So that's why we care a lot about that one, even though I don't have news for you today about it. This is just emphasizing that there's at least 3 companies been working on it, and they didn't tell us anything this time. There wasn't even any good posters about it. When we talk about gene therapy, which to me is a really exciting thing going on right now, remember there's 2 different ways you can do it. You can basically take the coding for the gene that you want, put in a little circle of DNA and inject in the body, carried in sort of a virus that we took all the bad stuff out of. And then you infect different parts of your body with this circle of DNA so you can turn that organ into a little enzyme factory inside your body. That's one way. That's usually what we call adeno-associated virus we use. to infect our liver cells and give them the little circle of DNA that makes alpha-galactosidase A for your body. And they can target it to the kidney, they can target it to the heart. It's kind of one way to do it. But the thing is, you can only theoretically get that once, because once you are injected with this adeno-associated virus or AAV, you make antibodies to it. So it's really important that you know, make sure you're doing the right gene therapy, and that's going to be the most effective for you. There's another way, and this is one that was really one of the ways it was developed in Canada, is you can take cells out of somebody, you can fix the cells, and then put them back in the person. So it's like a little bone marrow transplant that gives the cells the ability to make their own enzyme, and then put it back in your body, where then it can divide and you make even more and more and more cells that are able to make their own enzyme, which is pretty cool. The only downside is you've got to really dampen the immune system, get the cells, and then put them back in. So the chance is a little bit higher you could get sick during the dampening of the immune system part. And it does tend to impact the sperm, so it can affect fertility. So it's not something you do in a young patient unless they've banked their sperm or something like that. So you've got two different ways. One is take the cells out, put them back in. One of them is infect the cells that are already in there. How do you know if these are working? They're working if they get the enzyme levels up and the GL3s are stable or down. Stable if they've been on therapy before, down if they've never been on therapy or it just went down. And then you want to have minimal side effects. Sangamo presented their data. Darylyn Hughes, who's a physician out of the UK, who's great. And what she found is up to 27 months. So if you think about that, that's over 2 years. People's enzyme levels are staying up there. And if you look at this graph, this first graph that says plasma alpha-gal activity, the blue bar is basically what an average person would have. So like if you looked at my alpha-galactosidase enzyme, it would be within that blue line there. But what you're seeing is everybody went up. Some people hugely up, some people a little bit up, but everybody is up. And even those people who have come down a little bit are still within that blue bar of what would be considered normal levels of alpha-gal. That's pretty exciting. And the fact that we see some people who even have high levels way out to 850 days after they had gene therapy. They only got one dose, and this one dose is doing all this stuff. And you can see those lyso-Gb3s went down. And the people who had real high levels have gone down to a much better level. They're not normal, but they're much better. And those who had kind of normal levels or stable levels have stayed stable. That's exciting. That's doing the things we want enzyme replacement therapy to do. The other pieces that are really exciting is they felt different. So for quality of life, you saw a big improvement in how they feel. And we had to measure it looking at GI symptoms. We had to look at it using that question that everybody loves, the SF-36 questionnaire. That's the one that asks you if you're full of pep or not. Those found they were full of pep. So big improvements in how people were feeling and how functionally they were doing. 18 subjects, the ones who were on enzyme replacement therapy, everybody got off, and they've continued to be off for 33 months with their enzymes still high and their lyso still low. And the most exciting thing for the company and all of us around it is that they found that the eGFR slope, that's a measure of how your kidney is doing at 1 year, was actually a little improved. So not only did it keep it stable, but there was a little improvement average, right? Some people went down, some people went up, but in general, everybody was stable. So if that holds true for at least 2 more data cuts, so as people finish out that year after gene therapy, then they're going to be able to go in front of the FDA and the European Medical Association for review before they don't have to do another study. That's huge. Usually you'd have to do another study. It'd be another 5 years for us to know and able to get it over the, through pharmacies. So if this continues and this still looks good, then there may be an FDA-approved gene therapy for Fabry disease in 2 or 3 years. That's pretty cool. It's been really like 10 years, 10 years, 10 years, forever. Now, if all the kidney functions like totally go out of whack, then they're not going to be able to go to the FDA. But let's be positive. Let's be positive and hope that this continues on. There's other people doing gene therapy. There's one company called Unicure who's enrolling right now doing a liver targeted study, kind of like what Sangamo does. It's a different one, but same theory. And then 4-DMT has been working around the same timeline as Sangamo, but they were trying to infect the heart to make the enzyme make in the heart, because the heart is one of those things that we need to fix, right? And they had 5 US patients in the study, but they had some pretty significant reactions to getting the we call it a vector, but the thing that the enzyme, the modified virus that takes the circle of DNA into the heart and the body reacted to it. And so what they did is they found out something you could do to dampen the immune system, and they tried it out in animal models to see if they could give that before their gene therapy and if it would prevent the immune system from getting so irritated and causing problems. The biggest thing that happened is the immune system caused the red blood cells to leak out of the blood vessels, and then they go and clog up the kidney. So you get temporary kidney damage, or you get more long-term kidney damage. And that's why they had to stop the trial, figure out how to get the immune system to tolerate it better. And now they're talking about restarting it. So watch this space. They did show nice data on impact on the heart. People were doing okay. And the 4 people who got enzyme and kept it, but not one person was unable to, they didn't have their enzyme levels go up. It didn't work for them, but for other people it did. And they're considered clinically stable off enzyme replacement therapy. So watch this space. We'll see what happens next. But there was immune reactions to this particular gene therapy that they didn't see in the other 2. And then my final study to talk about with you guys got squished together. It's a lentiviral, not lentoviral gene therapy. This was a study that began in Canada. It was developed by Dr. Khan. This is the one that's like a little mini bone marrow transplant. And there are 5 very dedicated men who did this study early on before we knew what was going to happen with gene therapy. And they're doing quite well. 3 of them have stopped enzyme replacement therapy. They didn't have any giant immune reactions. Their hearts are looking stable or a little bit better than when they started gene therapy. Their kidney functions, again, stable or better than what they started at. And their plasma lyso-Gb3 is lower than when they started in 4 patients. Nobody's got cancer. And the reason we say that is because when you take a cell and you correct it, it can interrupt a place in the gene that actually prevents cancers from forming. So we always worry about when we do this kind of gene therapy, could there be an increased risk for cancer in some place? So far, no cancer. And they are looking for a sponsor. This particular way of doing things was, they ran some trials with AvroBio. If you heard about the AvroBio studies, they kind of took this information and did bigger studies, but they went and did it in Australia, and they kind of changed how they dampened the immune system before they got the dose, and things were a little bit differently done, and it didn't work the way that it worked for the Canadian trials. So they need to figure out why it didn't work in the Australian patients and not the Canadian patients. It's not like they were even worse or better, or their Fabry was that different. It was something that changed in the protocol and how they did it. So they're looking for a new sponsor. And the reason that we love this idea is that these cells, because they're fixed themselves, when they divide, they continue to spread cells that make enzyme throughout the body. When we do those other ones, the adeno-associated viruses, where you just inject and infect the cells, you lose that circle of DNA when that cell dies. It doesn't divide and give us more enzyme. So it's kind of like the pluses and minuses. Immune suppression versus maybe you get another dose and those cells reproduce. So what other questions do you guys have for me? Nothing is okay. You can always email me if you think about them later. It was a pretty busy meeting, even though we didn't hear much about substrate reduction therapy. There are people who are trying to fix Fabry in so many different ways. And I'm just grateful that we're able to have all these innovations and new ways of thinking about how to make life better for people with Fabry disease. I mean, I'm grateful for what we have, but anytime we can make things a little bit better or look for things that impact your life less when you're getting treated, I think are positives. So I think we still have a long way to go. Somebody asked me yesterday, I did this, you're going to love this. They asked for me to give an hour presentation about my career and what's happened through the years. So I did. I went through the whole thing. At the end, they're like, do you think you have still more work to do in Fabry? And I was like, oh, yeah. This is not ending anytime soon, my friend. So
Don, I always have a question about inflammation. It's something that I'm always wondering about, but I think it was a big topic this year. Seemed to be a
Yeah.
big there's a lot about it. And so just in your clinical practice or if anything, just throughout everything that you do, is there anything that you think that you would suggest to patients to kind of combat the inflammation?
Oh, I wish we had a good answer for that. I know that there's different ways through diet that you can try to decrease inflammation, but I don't know that it how much impact it does. Um, I think that the jury's still out about which pieces of diet or medications can help the inflammation. Um, I know that we talk about, GI things that happen where you have like slow emptying of food out of your stomach, which causes a lot of problem, then rapid through the intestines. And I think pondering better ways that don't cause problems within your digestive tract would definitely be diet related. But I think that we've got more work to do.
Mhm.
Um, I think that you've made some great strides with some of the work you've been doing, partnering with your naturopath who's kind of thinking about the whole body and ways we can address that. There's certain they're not medications, but they're supplements that talk about being anti-inflammatory. But I think until we have tried them in patients with Fabry disease, we don't know for sure how well they're going to change things or not. We do know that early therapy particularly kids under 10 with classic Fabry disease, seems to really decrease inflammation as well. So I think that for us who are over the age of 10, we're going to have to think about medications or supplements or things that are going to help us. And then we need to think about how to start treatment for kids earlier. And Gina's thoughts about newborn screening fit right in there with that, so that we have the option to treat earlier to maybe make a difference.
Thank you. Gina, I
Uh-huh.
think you had your hand up here. Oh, your mic's off. Oh, where'd you go, Gina?
Oh, jeez.
Oh, there you are.
My
All right.
son says to me, phones are hard, so imagine what computers are, okay? So, um, regarding, I was really interested just because my son just went through 2-day pain crisis,
Mm.
excruciating, and I hate to hear it, I really do. Anyways, you were talking about medications that are being worked on, they're not readily available yet, especially something that will go to the TRPN8 receptor, which is supposed to turn off the TRPV1 receptor, which you're saying is kind of what is believed to be the reason for these pain crises, which is the pain and heat receptor. So to give a cold counter shot sort of thing. Until something like that is available, because frankly, even though he's had some really bad ones, I actually reached out to Donna yesterday because, I mean, he's no longer living with me. He's 37. He's with his wife. He's stubborn as hell. He doesn't want my help, but I'm a mom and I'm crying on the couch, not being able to suggest anything. So I reached out to Donna and said, if you ever brought them to the hospital for some sort of pain medication, like what can I suggest to them? And I can only, I mean, I've had one or two in my lifetime and have never knock on wood. I've just grinned and bear it, and I get what he's doing, but um, in a hospital setting, like, is there some way? Because there's no way he could wait in our hospitals. He couldn't wait. He couldn't probably sit there for 20 minutes, let alone 2, 3, 4, 5, 6 hours in the midst of a pain crisis. Are there some suggestions? I don't know if hydromorphone as a tablet at home would be something that would work. Do you have any knowledge or suggestions that we could maybe have him discuss with the doctor? That maybe he can carry a letter, maybe he can carry a note, maybe she can prescribe him something to take the edge off at home. Maybe he has to go to the hospital. I don't know what the answers are.
Yeah, no, this is a really important question. Again, I'm not a medical doctor, but I do work with patients with Fabry disease. And one thing that we've had good luck with is a letter. And in that letter, we talk about a couple different options for treating it. Because just hydromorphone, you got to take a lot to get above that pain. It's because it's a lot of pain. So there's actually a couple of different combinations people can give. Some people give a steroid plus a pain medication plus like a more heavy hitting version of ibuprofen. And I'm happy to share that letter with Julia if Julia wants to share. Um, and it's something that they usually do in a hospital, but I have some patients whose physicians have been comfortable prescribing, like an in emergency kind of set of things. So like one dose of each of those things to try, and it seems to help. It really does. Now, on the non-pharmaceutical side of things, I have had several patients tell me that those float tanks, they're
Okay.
sensory deprivation tanks,
Yeah.
and the salty water is the same temperature as the body. It takes all those weird external stimuli away, and it has helped them.
Okay.
Now, I have not, I've tried floating myself, and I thought floating was really interesting.
Yeah.
But it seems to just taking out all of the stimulus seems to help some people.
Okay.
The other thing is that many times the reason the pain crisis is coming is because you're getting sick or you are
Yep.
sick
Yep.
or you've had that extra stressors, right? Or you push too hard. So I think also trying to figure out how to eliminate some of those things out of you. You can't,
Which is always
never
a
get
catch
sick.
22, right? Like
Yeah.
the stresses in your life, who doesn't, right? But yeah,
Yeah, everybody's got them.
that obviously today he woke up, he's finally feeling better, but he's got a cold. But it's
Right.
always the fever that starts, and then it's going to happen, and it happens, and it's just a matter of how bad is this one going to be, right?
Exactly. And so if there's a way to combat, the fever a little bit earlier to help it. But again, one of that things in the cocktail that they give in the hospital through this letter is a steroid to dampen the immune system.
Okay.
So I think part of that is, yeah, you're getting sick. And maybe just, taking regular medication to decrease the fever isn't going to help, but maybe dampening your immune system is going to help, at least with that immediate pain issue. It wouldn't be a long-term solution, right?
Right.
But it's
No.
like for an acute crisis time.
Yeah, and that's really all I'm looking to address, because everything he can be doing, he does do
Yeah.
for treating his Fabry, but it's in an acute pain crisis that ends up being like 2 days is a lot, like a full 48 hours of pain.
Of
It's just,
excruciating
yeah,
pain.
it's bad. It's bad. So
Yeah, it's
thank
bad
you.
and it wears on your mental health too.
Yeah,
So I'm happy to share that letter and he can talk about it with his doctor and see if there's any piece
that
of
would be
that they'd be
wonderful.
comfortable
Thank
with.
you. Thank you. Thanks, Julia.
Yeah, of
Thanks.
course.
Thanks, Don.
Yeah.
Rasha, I think I saw that your hand was up. Do you still have a question?
I need a bit more explanation on substrate reduction therapy, but I think I answered it by I was on the internet.
Ah,
So
beautiful.
I'm okay, thanks.
Yeah, no, it's good. Yeah, I'm happy to talk about it more, but really it's, the thing that's happening in our lysosome is we've got this pathway, right? And the pathway has a big molecule and it makes it smaller, smaller, smaller through each of these steps. And you have different enzymes that work all along there. And the question is, if you take them off that pathway and take them through an alternate pathway, can you keep it from building up? And then if it doesn't build up, then it can't cause the inflammation. So that's what it's trying to do. Now, I think that it's going to be more effective, like enzyme first or something to clear things out first, and then you take the substrate reduction to maintain that you're not building up more of it. But that study hasn't been done yet exactly. So they've tried different ones. But until they really show that it's safe and effective, then we don't have a good handle on it yet. But we've got some theories. There's a company called Idorsia that actually went through their phase 3 trial, and they didn't do well enough to give it to the FDA. They call it not meeting their endpoint. Their endpoint was improvements in pain. And as everybody knows, when we talk about Fabry disease, pain is like horrible one day, it's fine the next, medium the next. And so it's hard to figure out how you can use that pain all by itself as a, hey, yes, they're all better, because it's not going to go away forever unless we just, find a lot of new things to do or start treatment really early or combine like all the medications together. Anyway, so substrate reduction therapy, that was a tough way for them to try to get approval. And they're still holding on. There's still people who are on that drug. But doesn't seem to be moving towards filing for the FDA or getting approval right now.
Okay.
So we'll see what happens with the Sanofi one. Sanofi is using what's called a combined endpoint. So it's got abdominal pain, which we know we can get a little bit better and improve measurably, plus regular average pain, plus quality of life measurements. So my hope is that will be an easier endpoint to meet if it is working. It won't work. I mean, nobody's going to meet their endpoint if it doesn't work at all. But you've got to get an endpoint that seems good enough
Thank you.
and safe. Of course, safe is the big part, right? You don't want to take anything that causes harm to your body.
Right.
We have lots of thank yous to Dawn. Excellent summary.
Guys.
Sandy, thank you for that comment. It was just Sandy was saying that she heard from a naturopath doctor that maybe the potential food test, which is called the sensitivity test, can help identify some of the things that cause inflammation in the body. So thanks for that, Sandy. And then she also asked, is there any news on AI that can potentially be helpful in rare diseases?
Yeah, I think AI is getting harnessed in different ways. One way is looking through big data sets to find people who could be at risk for Fabry disease. That's a cool one. AI is using, well, they're doing stuff like, helping make you schedule your appointments, right? Or asking like basic questions about labs. Those are kind of the big things. AI, they're also trying to look for therapies. So they'll say, oh, this therapy is on the market or there's this mechanism. How can we go through the stuff that's already approved and find one that might work for what the problem is? So, for example, activating that cooling receptor, they're going to look through their medication library with AI and other things to see what else might be useful. So, AI has a role for sure. I think that we need to use it responsibly because it's only as good as the tool we use. It's only as good as the data we give it. AI really has to be well trained and then it has to do a task that it's good at. AI is good at taking large amounts of data and finding patterns that we can't see as a human. The question is, does the pattern matter or not? Sometimes they'll put together something and you're like, well, that's weird. And sometimes it can get what are called data hallucinations, where it believes something to be true that is not. So I think AI is going to be very useful, and I think we just need to wield it with expertise in Fabry disease and input from everybody who has Fabry disease.
Thank you. And I wanted to quickly just mention when everyone's still on here that we are doing a workshop. It's a functional medicine naturopath workshop. It's starting April 4th. It will be on Fridays for those of you who live, so it's, it's in Canada, but Eastern time will be 2 p.m. Friday afternoon. So you can do the difference with whatever time zone you're at. It's with Dr. Conwell. And we're going to be focusing on different topics, hormones, nutrition, pain, all these great things to try to figure out what and how we can, what anything else that we can do. So there's all the information. We have a flyer or brochure. It's on our website, so check it out. Registration, we have 4 more spots left, so I wanted to let you know about that. But Dawn, you are always so lovely to listen to. I think everyone can say that, and we just appreciate you spending this time with us. I know I was hoping it would be a yes when I said, "Hey, 2025 World Symposium highlights," and you're like, "Thumbs up," And we are just on behalf of everyone here, we do really appreciate it.
Well, thank you. I love speaking to you guys. You always have great questions, and I just feel like, the more information we share from these meetings, the better it is for everybody.
Absolutely. Yep, absolutely. And thank you for everything you're doing in the Fabry field.
Sure, of course. Thank you guys for participating in all our surveys.
Thank you.
Thanks, everybody.
Thank you.
Bye.
Good night, everybody. Thanks for joining.
Bye.
Bye.